All right. Thank you to our panelists for all of your introductions, and we will now open it to the committee for any questions. So, okay. Yeah.
Yeah, I was interested in hearing a little more from Dr. Murabito about the Framingham approach to dealing with CLIA. You have kind of a novel approach, I think, to that. And also hearing a little more about, as Dr. Buchanan provided, a little more about the experience of having returned results. What have you learned that would be helpful to those of us who are about to do that? Just the actual practical effects of returning results and any unexpected findings and that sort of thing.
So what we learned that sorry about that. So in terms of our experience with the issue with CLIA, our lab was not, our genetic testing was not done in a CLIA certified manner. So we had gone through a full process in identifying what might be medically actionable with our committee, and we're ready to return results, and then came up against this issue and looked to the legal environment for how we might be able to circumvent and provide results, because we felt that we ethically needed to do this. So what we ended up doing was to make a phone call to participants, identify whether they still wanted to have those results, inform them of what the GINA regulations were. If they still wanted to proceed, we would just provide the result for the gene of interest, have a genetic counselor available to them, follow up with written materials that said these are research results only, they do not meet clinical standards. You need to have this, you need to discuss this with your healthcare provider. No medical or treatment decisions can be made with research results only, that these would need to be confirmed in a clinical laboratory if you decided to go forward. And then we would, a physician would make that initial phone call with training and scripts that were developed with the team, including a genetic counselor with that first phone call. Then there was a letter that went out in follow-up. Once we got permission to contact the healthcare provider, that information was then sent to the healthcare provider, again, with, do not place in your patient's chart. This is not confirmed, it's research only. Please have a conversation with your patient to make a decision whether you want to move forward to have this confirmed in a clinically certified laboratory.
So you don't disclose the specific variant. You just guide to the gene.
We were advised that because it was a research result only, and because of the CLIA issues, that we could not disclose the particular variant. So we had different advice than, we had a different interpretation of the law than Barbara's interpretation.
Joanne, when you say the specific variant call, is the gene itself disclosed, or just the gene?
Yes, the gene itself was disclosed, but not the variant in the gene. So there were two genes that we felt met medical actionability that we wanted to move forward with.
Dr. Wallace talked about a very challenging population for return of research results, and I work with a similar type of population at times as well, and so I hear the pain of being able to do this kind of thing, and it sounded like you haven't had that much experience yet with the return of results, but I was wondering from both Dr. Buchanan and Dr. Murabito, whether or not how much you have worked with the intended recipients of the results, thinking both the clinicians but also the research participants themselves in designing the process and the actual presentation formats for the return of those results so that they could meet the needs of the various target audiences. And I'm thinking of that also in the context of all of us with the intention of really having a diverse cohort. So I'm wondering what we might learn from you in that regard.
We have engaged a variety of different groups. So we have a clinical oversight committee that helps us match the culture of the institution and how primary care and other clinicians like to get information and incorporate it into care. We have an ethics advisory council with some local patients as well as some bioethics experts, and that meets quarterly to advise us on some of those same matters of how we might disclose information and incorporate it in such a way that meets the participants' needs. We have a recently founded Precision Health Participant Advisory Board, which is a little bit of a different composition, but it's a similar idea of a group that can advise us on those materials and on how to make sure those are not overly complex or usable, or the kind that can be shared with relatives so that we can try to have a population health impact. All that said, I still think we have room to grow in making sure that how we're communicating is actually consistent with both a diverse audience and meets people where they are and allows us to figure out how to match that form of communication with where that participant might be. I think room to grow there, and something that the folks on our team in genetics, we like genetics, we think it's interesting, but not everybody does. And so we've got to figure out how to meet people where they are. I think the other challenge that we've had in terms of communication is some of the things that we're returning are things that patients already knew about. So we have a couple familial hypercholesterolemia genes that we're returning to people who already knew they had high cholesterol. And so trying to convey the impact of that information for people who've been treated for high cholesterol for many years can be a real challenge. So I think room to grow there as well.
Right, so we have gotten feedback from participants just through our ethics advisory board, and what we do know from those participants is that they do want the research results, including the genetic results. We also did provide some results back from hemochromatosis. We did do a post-result survey, and the participants really were grateful to get those results. I think Dr. Jaffe also did a survey of our participants for hypothetical situations, and I think 90% of participants wanted the genetic results across all of those situations. We haven't actually engaged participants in the way the actual results are provided back to them. We actually have engaged content experts for the particular gene that the result is being reported back for, and we've engaged a genetic counselor so that when we prepare materials and scripts, that the content expert, investigators, and the genetic counselor review all of those things, and that the staff and the physicians are trained prior to phone calls and written materials going out. that both the participants and the healthcare provider for the participant have contact numbers for staff at the heart study should there be additional questions and phone calls in. And because we're a longitudinal study, many of the participants have known our recruitment staff over many years, and so they're comfortable calling back in if they do have questions.
I do want to comment. I mean, one thing that FQHCs are great at are helping to facilitate. If we have resources, we are great people in facilitating understanding with our patients and care. We send care managers out with iPads to have visual contact with patients. We're going to be piloting doing clinical pharmacy, hypertension management. We can find people. You know, we can help teach. We use a lot of telehealth services. So again, a part of it is, I agree, we're not trained to understand all of the implications of a specific genetic result. But we can certainly help if we have the resources to hook people up to those consultants, or, you know, again, teaching. You know, if my providers can hook into, you know, some learning opportunities, we want to take care of our patients, and we want them to get these results, and we want them to have the opportunity to partner with us, again, based on their values and all their total health, to make decisions on the basis of the results.
Moderator privilege on this.
Oh.
I'm just wondering, Joanne, you talk about training physicians to be effective, you know, counselors at some level for genetics. And Phoebe, you were talking, I'd like to be educated in genetics. I'm just wondering what the model is. Are people coming to you? How are you giving the training? And what training would be most effective for you?
When I say the physicians are investigators at the heart study, so we want to be effective in giving the information to the participants. So it's something that we initiated. And the one very important thing that I did not mention is that this whole committee structure and results reporting and all the effort that went into this was unfunded. And so all of the committee meetings and all of these multidisciplinary people that developed this reporting structure and all of the reporting that happened was unfunded. Moving forward, because we're in Framingham, which is 18 miles from Boston, we have now partnered with two experts working with the ACMG to put forth a grant to do this in a more structured way, and hopefully that grant will get funded.
I think we need a curriculum. I think we need a curriculum that I can take to my providers. I mean, we're a 23 clinic healthcare system, but you could do it through primary care associations. There are a number of mechanisms, the National Association of Community Health Centers. There are organizations where you could take curriculums that start basic. I think we got to start basic and start training and preparing our staff. You know, what's painful is somebody comes in and boom, you've got this complex problem you have no clue about to doing, and you just, you know, it's like deer in the headlights. I can't do this. But if you build the foundations, and I think that's what we need to do, is build foundations for primary care providers, so that as there's more knowledge, as there's more information, that we at least have the beginnings to know how to go. We do this all the time. We're now learning how to do treatment of opioid use disorder in primary care. So we, you know, HRSA funded for us to participate in ECHO from University of New Mexico to have training. So there are mechanisms to train, because primary care is where most of the care in the United States is going to go, because we're the most cost effective, and we need to utilize the resources of consultants in appropriate ways. And so we're I said 26 million. It's anticipated that figure in FQHCs may go to 50 million over the next 10 years. So we are part of a huge part of the population in the United States. So we need to be prepared. And I think if you reframe it for primary care, like one thing I tell my providers, you're taking care of the substance use disordered patient. You take care of them every day. They're your patients. The fact that you've got new genetic information, they're your patients. So let's learn how you incorporate that knowledge into the care, taking care of all aspects. See, I think in a very holistic, again, population-based is where we think in the FQHC world. So how can you take these individual pieces of information, because a person's not a sum of their data, and how do you make that work clinically?
Okay, I've been trying to keep track of order here. I think I have Greg, Wiley, Stephen, Jeff, Deborah, and Paul. I apologize if I might be a little out of order. Greg?
So I want to keep on the discussion with Dr. Wallace. So what I'm hearing here is we're in danger of creating some sort of informational apartheid, where if you're at a federally qualified health center, you're going to get less than if you're in the orbit of some big academic medical center. And this isn't just about genetic results. And I want you to generalize away, because this is not just about your DNA. It's about all the other kinds of biological and non-biological tests. What would you need in addition to a curriculum at a federally qualified health center like yours to take advantage of the richness of the information that's coming out of research studies that might help patients now or might help them 2 or 3 years down the line? If you're looking at, in your daily life and the way your clinic runs, what else do you need in terms of a curriculum to make it possible for you to use new sets of data that are coming down the line?
Well, again, I think I'd start assuming that most providers don't know anything. And so again, I think you've got to start basic, but you have to do it in steps. We're busy. I can't take people. One problem with the ECHO model is taking people out of clinical world for 2 hours every other week. We've got to fit whatever we do into the fact that we have lots of patients to see. And we have, what are we incentivized for? It's RVUs transitioning into value-based care. And so we're going to get paid on whether that person has an A1C under 9 or whatever parameters. So we have to fit the training structures into bites that we can do at lunch times, we can do in snippets so that you can absorb it. Podcast is huge among, things that people can listen to driving to work is really huge. So multimodality ways to train and to give the information to providers, we appreciate. And again, it's a balance. The struggle of primary care is way beyond the scope of this, but we are asked to be doing more and more and more, and to be our advocates in CMS, to again payment structures to help us have these kind of ability to train. If they want us to see more patients and do more things, then we need to have their backing and their support and funding to help us do so.
I'll throw this out with what VA does. And if you think that roughly 85% of residents that are trained in the United States actually cross the path into a VA, that's actually where you get most of the information as well. There's strong academic and VA partnerships throughout the country. But that's not enough. And so we kind of looked at how do we build out another level of information on genomics. That really was the first forefront that we pushed into was with the nurses. You get them to understand what the basic information is, because the clinician may or may not have the time nor care, unfortunately. The patient certainly will want to find out, and the nurse is going to be available, not as much, but still available. So there's that twist. From a pharmacogenomic standpoint, we're educating the pharmacists, because nobody seems to have a good, clear understanding of variant star 3 or whatever of something. But these guys do. They live and breathe pharma. Educate them so they actually get better at what they are. They're actually more, and more stable, they're actually more needed, and gives them another edge into their own occupation.
One other note there about trying to manage this complexity is we've, as I said, we have a patient population with a lot of complex disease, and so sending folks back to primary care with a genomic result doesn't necessarily mean that that helps them manage that result. And so we've been looking at models like health navigators or patient navigators that in our primary care clinics and in other settings like oncology can help navigate. You know, right now your priority might be getting your A1C down. 5 years down the road, it might be beginning risk management for your BRCA result. Perhaps right now we want to help with the family communication about the result, and that's the thing that can impact. So trying to understand precision health broadly, not precision medicine, and to impact, both assess and impact social determinants of health and the other things that are involving that person's care is, I think, where we need to be and what we're trying to transition to.
Okay, thank you. Wiley?
I'd like to ask you to reflect a little bit about the issue of actionability as a criterion in returning results. I think it's intuitively attractive both to participants and to researchers that actionability should be the driver for what we prioritize to return. Just in terms of two dimensions, one is that actionability it takes many different flavors. We really like the actionability part where we're finding a particular risk where with appropriate health care, people's outcomes can be very good, the hemochromatosis type of example. But actionability might, I would think, also involve finding a big mass on the lung x-ray that needs workup and really does need it, but it's not a good prognosis. And taking that thought and sort of extending, it seems to me that we also have the potential in clinical research to identify results. I think we've already heard this morning, results that might be considered highly valuable to the participants. I would describe in particular results that have high predictive value. Even though they don't have medical actionability, they may yet have a great deal of personal meaning. And so taking those kinds of examples in mind, how easily can we draw a bright line? To what extent should we be thinking in terms of pushing some results but making others available? I'd really appreciate your thoughts on that.
So, Eileen, great question. The thing is, though, having a research result will be only as good or as valid as the assessment of the test standard that was performed for the validity of the test itself. So having a person that might be a postdoc working in a lab coming up with an answer and finding that, oh my God, this is an RS something that's going to be detrimental, it makes you kind of wonder if that really is true or not. The flip side, at least for VA, is that these are clinicians and the medical practice that they perform will take that into account and at least try to answer the question. So there might be a marker that has some significance. They will find a way to get that validated, either with the academic affiliate or another company that might be at a CLIA grade type of study to be able to answer that question. So in a way, they are hinging upon that variant that has kind of got an idea going in their head. They could also go to the point of saying, I'll put this in a medical record because there might be something, and I don't understand what the absolute answer to that is. I think the distinction that, if I may put, is if you look at, as you were saying, having an x-ray, and as examples, we have multiple studies on veterans with PTSD. They do MRIs of the head. And lo and behold, they find a malignancy. Well, it's criminal for you not to say something. But when you dissect that out, you see that you know what the image looks like. You know what this is correlated because of the multitudes of studies and answers and follow through that has been done So it's criminal because everybody else knows and you don't. That's where the criminality comes in. On the other hand, if I were to say an RS 10022 is a variant for you, well, yeah, I mean, that might be interesting. I might understand from the current literature that there might be a link. And now going with my medical reasoning, I could say, there's something that's kind of interesting. I think we need to pursue this. That's the angle that most of the research from a non-CLIA perspective is done, at least with VA.
I'm hearing you say that actually an important responsibility of researchers is to have some handle on how much certainty there is in this result that they have in front of them. And that's going to be due to factor in a lot of aspects like what do we know about the technology, what's the nature of the result, and that might be as important as the actionability issue. I wonder.
I do think, you know, again, thinking about my providers and the skill level that I have, you know, if you get a result that without some guidance, what's going to happen is what people have seen is you get excess tests, you get other stuff that may or may not be helpful and may misinterpret the finding. So again, that's part of some of the guidance, because I can see where, and I hope that this is going to be looked at, is what's the increase of healthcare cost that occurs as results are starting to be released. Because I think that bears a lot on, you know, our healthcare system as a whole. You know, I see it all the time with, you know, in my state, we look at 20% of the nurse practitioner charts, but then I'll find out that, you know, something's been ordered that I would have never in a million years advised them to order Chase or whatever, because they don't have the skill level. So you just have to take that in a balance. Again, that's where we, you know, hopefully can get some support and guidance and at least some direction. Maybe in a FQHC we could, for particularly our larger ones, identify the providers that maybe are the more skilled in interpreting these things and focus on training those to help with this, so that, you know, those results would be reviewed by them or a panel and then help to guide the providers.
I have a couple of additional thoughts. I'm not sure either one is terribly helpful, though. But one is that even when you think you have a bright line drawn between actionability and not, for example, in the setting of, say, BRCA 1 and 2, where we have 20 years of data of reduced morbidity and mortality when we identify mutations, in the setting of a research study that's returning a secondary or incidental or additional finding, because of the method of ascertainment, the penetrance may not be the same in that population, and therefore the cost-benefit balance of whatever procedures you might do could be different. So perhaps that argues for moving for a more conservative line there for where you draw it. I say that knowing that geneticists are fairly conservative anyway, and we often end up being wrong. But that's one possible approach. But the other is that I wonder what the role is here for participants to help make those decisions too. And that's a consenting challenge or a participant engagement challenge, figuring out how to communicate information about what you might get and when and how impactful that might be. But I think that should be part of the conversation and could provide some guidance.
Thank you. Jeff?
This is a question from Consuelo Wilkins. Which of your approaches to returning results are easiest to scale to a very large, diverse study population, and which are most challenging to scale?
I'll say at least from a VA perspective, it's the standardization of anything. And the rigor that needs to be stated in any processes to actually function within a system as large as ours. That's always the challenge. Once the question is sort of answered, you see what you need to hit against, things fall into place very quickly. It's just how do you put the standard, the information, the boundaries, and the expectations, so everybody actually takes that and uses it. That is always the problem that we run into.
Ron, can you offer a kind of an illustrative example of that?
Well, I think one example is this. Several years ago, there were the drug-eluting stents and the bear stents. Nice study from cooperative studies programs. Lots of people went through. Clear evidence. You want to use the non-drug-eluting, the bear stent. When you look at the use of that, all of a sudden the drug-eluting stents drop. 3 months later, they go back up and they stay. It's as if nothing happened. And now how do you push that into the system, understanding that you can't say, well, these are more expensive, because then you will be having a talk with Congress. You can't say that the drug-eluting stents cannot be used because they are available. You cannot say that, well, the study is definitive, but you have to have an answer that appeases to everybody. And the appeasement to everybody is always the difficult part about this. So you have some halfway assessments of this. You allow the clinician to further investigate and get more follow-up information, and then so years go by. Meanwhile, it doesn't really reflect the absolute answer of we should be going to bare stents. I don't know if that answers the question that way, but it's every one of these things is a quagmire, let's put it that way.
I can tell you where our bottlenecks are for scaling and how we've been thinking about addressing those. So in a process where we're starting with a research whole exome, having that reviewed for potentially concerning variants in those participants, having a clinical confirmation, returning that to care, there are a lot of steps to go through. And so the initial evaluation of variants is a bottleneck. The clinical confirmation is another. Having the clinical team in place to support that return is another potential bottleneck. And then the communication with the relatives to try to facilitate cascade testing. Those are all places where you can drop out of the process and lose your potential for having the population impact that you want to have. So we've been thinking about ourselves as having a genomic screening program where we can use available tools from ClinGen, ClinVar, other curated resources to try to prioritize specificity, perhaps at the detriment of sensitivity, as a genomic screening program to increase the throughput of analysis of variants. We've been building out our clinical team and using alternate service delivery models, phone, video, exploring use of consults directly to patients' devices, and so that we can reach more in a timely fashion, using things like chatbots to offload some of the clinicians' communication that would be more or less standard for most patients, and then trying to investigate more direct methods of contact for relatives. So not the passive approach that we typically take in genetics of telling our particular patient, we sure hope you talk to your relative about this and please have them call us, but investigating how we might be more direct about that. So those are the things that I think would have to happen to scale, and the things that projects like All of Us are going to have to address as well.
Steve, I had you in the queue. I know you stepped out, but we skipped over you. So.
Thank you. So actually, this question is directed to Adam. You have an infrastructure at Geisinger for doing this, people who at least part of their effort is dedicated to doing this. I understand that the sequencing itself is paid for by Regeneron. Do you have any sense of the resources that are dedicated to supporting the infrastructure for the return, and what some flavor for what that is, how much that is? Sure.
So we have multiple percent efforts, if you want to think of it that way, for geneticists and for a team of about 8 or so genetic counselors right now, plus staff members who are kind of our frontline communication there. We'd like a bigger team. So there are I think, health education experts that we can engage and others that we can bring into the team. So it's a big operation, and that's not that's a system that's there because the institution has made a commitment to doing it, and is not necessarily generalizable.
And if I, just to clarify one thing, if I understand correctly, it's the rare Geisinger patient who gets something back. So you're doing very large-scale sequencing, but it's at the end of the day, it's a small number because you've a modest number of genes, highly penetrant variants, pathogenic, et cetera.
Exactly. It's about 3.5% is what we're seeing so far. We're, as part of Emerge, moving toward returning pharmacogenomics results, which will be nearly everybody, but that'll be a different model.
I think Deborah's up next.
I think others have asked the questions that I had.
Paul?
Yeah, so my question is not unrelated to Steve's, and it's sort of the inverse of the question that Consuelo asked about scaling. There's a majority of you on the panel who are involved with very large-scale studies, right? My Code, Framingham, all of us. And you've either built or are thinking about building very impressive infrastructure, designing scripts for providers to return data, extensive outreach, web-based communications, and the like. To what extent do the approaches that you've been involved with seem likely to be able to scale down? Many smaller studies won't have the kinds of resources that you have available for your studies, and may not be able to do all the things that you've been able to do. Should we be thinking about one standard of return of results for large, well-funded studies and another for small, impoverished ones, or is there some way of thinking about a more generalizable approach across the range of clinical research?
I wonder if there's some common elements that you might see across all types of conditions. I mean, kind of off the top of my head, you'd want to be able to have a result that you felt confident in, and that was medically important or otherwise personally important to your population. You'd want someone either involved in the process or at least accessible who understood that and what it meant for that participant in their care. And you'd want the ability to have that information resource available in some capacity to the front lines, primary care or other specialists. You can do that in a fairly slimmed down fashion, I think, kind of meet those conditions, but I think that's kind of bare bones.
I agree. We had some very, some commonalities, even though Framingham is much smaller than Geisinger. We also had sort of our ethics advisory board where we were engaging participants, and that was meeting quarterly. And I wonder if there's some way to have that across smaller studies where there was some engagement of key players, participants. We had a local physician on our board and some community leaders, and whether there's a way to have some sort of network like that, providing input into what's important to the study participants and community, and how to get those results back in a meaningful way.
So I'll say, at least from a Million Veteran Program, we do have around 500,000 of the folks with the Affymetrix Biobank chip done. About 30,000 with whole exome and a couple of thousand with whole genome. We have multi-site studies to identify specific issues that are related to the veteran, and as they are coming about with results, to then have verification and then push this into the VHA system itself as a standard of practice. So I guess in a way, you're really looking at the downscaling. You're not taking the whole kit and caboodle in here, but you're really looking at specific markers for a specific aspect of a disease. And now you're just working with that from the panoply that you have at hand.
Okay. Suzanne, I guess you're up again.
Hi, I think my question is mainly for Ronald and Adam, but other responses as well. One of the things in terms of scaling, we think like now most healthcare organizations are including a patient portal. I think it's upwards of 90% now. And so I was wondering if and how your patient portals are involved in this activity.
Are you asking from a genomic standpoint or in generality?
Reporting laboratory results, including genomic.
Well, the laboratory results, if they are clear, the patient can pull that through HIPAA because we have the designated record set. If they do want to find a specific aspect, let's say I come in, I'm a veteran, and I know that I went to this MVP program and I want to find out, since my parents had Alzheimer's, I want to find some of the markers. I found this on the web. Can you give me if these answers are there? They certainly can ask and find that information. They need to have the patient, the clinician, to also discern and explain what this means, which, so the patient needs to know what they want, the participant, as well as the clinician needs to explain and be understood by the individual. That is a possibility from that aspect. A portal where they can actually just go ahead and find that information, nope, sorry.
And we use the patient portal, which is like a lot of electronic health records in the way that a lot of clinicians use it to communicate with their patients. So if we're sending a written notification about a result to a participant who's signed up for the portal, that's how we start, is by sending it through the patient portal. As for how much of information that comes back about the result that they can access through the portal, that's limited. So a genetic test result is a PDF and they can't see that in our electronic health record. They can't necessarily see all of our notes that go along with it or the interpretation of the result. One thing that some colleagues have worked on is a patient-facing report that communicates with the electronic health record to provide some more interpretation of that result, both for the patient but also for their clinician too. So that's something that they can view through the portal.
All of us the information is going to come through electronic means, separate from anything we do in our medical record. So if a participant wanted us to have a report, they would need to pull that information and give it to us separately. We actually are keeping everything, all of us, separate. None of it is in the medical record. That they're participating is not in the record. So right now we're keeping it very separate.
I'm not sure who was up first, Deborah or Jeff. Do you know? Okay.
So the work that you're doing is in a clinical setting, really. I mean, to some extent, and intended to generate results that likely participants will want to know or may influence their care. Have you learned anything that would help inform how a research laboratory, just doing discovery research, gets asked by participants whose samples they happen to be using in a world where that can be identified? How should that research laboratory and those researchers think about returning results when they're requested by a participant and they weren't thinking about returning those results at all? Has anything that you've learned, done, could inform that situation?
We've had this come up a couple times where an investigator who has access to de-identified data says, I think I've got something here that's going to be medically important and I feel compelled, I feel a duty to return this, but I don't know how. So that's initiated by that investigator. From the other direction, from a participant saying, I want some information, we haven't really figured out a good way to deal with that. In the former condition,
You haven't
encountered.
You haven't encountered it. It's not that you don't have a way to do that. It's just that hasn't ever happened.
That hasn't occurred.
So I'm not sure if this is the same thing. At Framingham, we have many ancillary study investigators who interact with our participants. So our participants come in, they give many tubes of blood. Some of these ancillary investigators are just getting a laboratory sample to do an investigation and then may use some of the clinical data. And they would use the same sort of analytic framework if that, whatever they measured in their laboratory, in the sample, had some clinical relevance, then that PI would come back to us and to the main study investigators, the main overall PI, and say, I think I have something here. And we would review that and make a decision together, the overall study investigators. And then we would go to our IRB and we would make a decision about whether that met criteria to inform. And we would take the responsibility with the study investigator to inform participants if we felt that it was medically actionable.
But that's the researcher wanting to communicate, not a participant just requesting their results, all their results up to even raw data from the research that they're participating in.
Right, so we haven't had that situation where a participant requested all of their research results. We haven't had a situation like that.
It all depends on the consent and how the IRB approves or disapproves. What manner, how much information, how do you deal with the unexpected results? That's all in the consent itself, and it certainly could be brought back to the given individual.
Jeff?
Yeah, mine's sort of a two-faced question, and maybe primarily for Joanne and Adam, and I may have missed this, but for your studies, do participants get a choice about whether they want to get results back? And if so, can you anticipate a circumstance in which you would override that refusal? I mean, given the sense that oftentimes consent's fairly generic, you don't know what you're going to find. Are there circumstances in which you would override a refusal of results? And then second phase of the question is, have you made provisions for when your participants lose decision-making capacity, and how would results be returned to legally authorized representative or family members, et cetera?
So the way the consent form is written is that if we find something medically important, we'll tell you. And if you'd prefer for that not to be the case, then it's probably not the right study. That's how we've gotten around that sticky issue of trying to figure out how to handle the decision-making there. For the loss of capacity to make decisions, there have been people who have participated but then passed away, but we have a result in hand because we didn't know that they passed away. It's not documented in the record or otherwise available. And so then we've had to work out a system for how to communicate that to next of kin. This may still be, as genetic information is, important for the rest of the family. So it's not that there's no longer capacity to make a decision about a result, but there is a question about to whom to give that result when the participant's not available.
So our consent form actually is a little bit different. You have a checkbox to opt in to return of results and separately to opt in to return of genetic results. So we have not had a situation yet where there's been a result of importance where someone has opted out. We have had results where a person may have undiagnosed diabetes and doesn't want to get treatment. That's a different condition, and people have free will and have the right to decline treatment. We do have an active dementia study, so we are able to identify people who don't have the cognitive capacity to understand, and we have had a situation where, for instance, when we were returning results on hemochromatosis, where people had no longer had capacity to receive those results, and we did not return results to those participants.
And I'll just add that one thing that we've considered doing with our consent form is asking participants to name next of kin, power of attorney individuals who might be able to make that decision for them at that time or might be able to receive a result. We haven't put that through the IRB yet, but that I think is something that we'll add. It's helpful to have in a study that's been going on not nearly as long as Framingham, but still 10 years, where the original participants are not always around.
I had one additional question for the panel, and that is thinking, as we were discussing earlier, about the kind of extended educational model, providing instruction in genetics for primary care providers. So on the clinical side, as many of you know, I'm sure, we're facing increasing challenges from payers in credentials in being able to convey genetic information to patients. So certain companies require that either a geneticist or genetic counselor pre-counsel families before they will approve certain types of testing. And in fact, in Tennessee at least, we cannot use surrogates unless they have very specific types of training. Nurse practitioners, for example, with extended genetic certificates of some sort, are allowed to do limited amounts of genetic counseling, but we can't have our neurology colleagues say, oh, I know genetics and I can do that. So I'm just wondering, in the context of return of results using, I mean, is this a different standard, do you think, as far as conveying the information, or is I understand you have backups and clinical folks who can talk more about this, but in environments where that might not exist, how do we think about that and the return of research results, and at what level I think we should feel comfortable in allowing?
Well, I too am in Tennessee. I think about it again. I'm thinking about hepatitis C, where in Tennessee, you, as a primary care provider, if they have Medicaid, you can't treat hepatitis C. You have to refer it out, which, with changes in education and changes in training is ridiculous. But I do think when you're talking about something about genetics, that it's very state specific and having some standards, but you have to balance it in reality. I mean, if everybody had access to a well-trained genetic nurse practitioner, that would be nice. I'd love that. We'd all love that. I do team-based care. I'm fine to have somebody do that, but I think even though that may be now, the goal will be to have more and more that people trained within primary care, because primary care is where people go, and particularly when you're talking about low socioeconomic, particularly rural places, your primary care provider, and they're going to come, even if they talk to you, they're going to come back and ask me if that's legitimate. Or more often it's, I didn't understand what that specialist told me, can you tell me? So how can I tell them if I don't have some education? So anyway.
I think one of the reasons that insurance companies have instituted policies of a pre-test counseling being done in that context is to help choose a test that they don't have to pay for when they shouldn't, and so that they can get someone with the expertise to pick the quote-unquote right test. In the setting of research where we're thinking about results to return, then I think you can accomplish something similar with the way that you make decisions about what you return. So that if you're pulling that diverse group of stakeholders together and making a decision about what you might return and what the process might be for that return, I think that's how you can get at the same goal.
Yes.
I apologize if this question's been answered when I had to step out, But all day we've heard people talk about they have boxes, opt-in, opt-out. But what I'm trying to grapple with is, what does that mean to participants? What does it say? When it says you can opt in for your results or opt out, is that all it says? How much more information are people given in order to make an informed choice about what box to check?
So I'll throw this back out. When we launched Million Veteran, we actually had an individual, Kathy Hudson, do a study for us of veterans asking, do you want to opt in or opt out? And I think the altruism really came through because they didn't care. And the understanding was, at least from what I gathered from veterans and from the survey itself, is that I'm not doing this for myself. I'm doing it for the other veteran and those that come back. I think it depends on the population.
So I think consent is a real challenge. And even when you think of a consent as a process, it's typically a one-time process. It may be, we're all asked by our IRBs to give people a chance to go home and think and to come back with questions, but that rarely happens. So most people make decisions in 15 minutes, perhaps less, by reading through what can be a complicated form. That's not necessarily conducive to making an opt-in or an opt-out decision. And so I think the challenge is to find out a more longitudinal, engaged approach there, where maybe the first thing you do is sign up for the study in general so that you understand the basics of it. Maybe the next contact is a discussion of a particular opt-in or opt-out, where you have, again, a similar process again. And every time you add something new, it's a different communication process. That's more conducive to the way that humans learn, I think, and is a little less overwhelming. Sometimes with the way some studies are set up, you can't be counted as quote-unquote enrolled until you've done all the things first. So that doesn't always fit, but I think that meets people a little bit more where they are.
All right, it looks like we might have time for one question, perhaps from other participants who are not on the committee participating. Are there any takers? Yep.
Thank you. This has been really fascinating. I'm so fascinated by the difference between the interpretation at Framingham and Dr. Jarvik's interpretation of the return of results. Is there any interest on Framingham's study's part to reopen that discussion based on experiences from other locations, or are you satisfied with the way you're doing it? And it just feels like they're so different, and I'm wondering with that spectrum where others might fall in between them. So, thanks.
We would have loved to be able to have provided more information. Our legal counsel had actually reached out to several other legal counsels, and the interpretation of the law in Massachusetts was just different than the interpretation of the law in Texas and in other parts of the country. So that's what happened. We had actually were all set to move forward with return of results and had actually prepared different scripts and different information packets after conferring with content-specific experts, and then got put on hold after conferring with our legal counsel at our home institution. I believe it was a state issue, or at least the interpretation of CLIA in Massachusetts versus other areas.
All right, if there are no more questions, again, thank you to our panelists and for a very robust discussion in this section.
Good, my thanks as well, and thanks to Chester. And we are going to